Well, welcome to today's webinar. I'm Mandy Sankoler, your Director of Partnerships and Communications, and it's our absolute pleasure to have this session today to talk to you about obesity, inflammation, and their relationship to cardiac health. A few housekeeping items before we get started. Please note that all attendees are in listen-only mode. We will not be able to answer any questions related to your specific condition, but we do encourage you to take any questions you have back to your healthcare providers. Please type your questions into the Q&A box so that we can answer them at the end of the presentation. And in case you want to share this with anyone else or go back and review it again, it will be recorded and available on our website and YouTube channel. We would also like to thank our supporter Novo Nordisk for this opportunity to bring this education to our membership in the community. And now I would like to introduce you to today's speaker. Dr. Michelle Ponder is an assistant professor of medicine in the Department of Endocrinology and Metabolism at Duke University School of Medicine. She attended medical school at Jefferson in Philadelphia, completed her internal medicine residency at the University of Maryland, and completed her fellowship in endocrinology, diabetes, and metabolism at Duke. She is also board certified in obesity medicine. She practices as a general endocrinologist with a focus on obesity management and serves as a member of the Cardiometabolic Prevention Clinic at Duke. We are honored to have Dr. Ponder here with us today to shed some light on, I think, what can be a very confusing metabolic relationship. So Dr. Ponder, please take it away.
Thank you so much for that introduction. I will share my screen. Just give me a couple minutes here. Okay. Oops. Here we go. Click a couple buttons so you can see it. Okay, can you see it?
We
the
can.
slides perfectly? Okay,
Thank you.
great. Well, thank you again for having me here today. I'm really excited to talk about this important topic and obviously something that I'm very passionate about. As an endocrinologist and an obesity specialist, I love doing what I can to do the best and most thorough evaluation for my patients to help reduce their risk for cardiac disease as well as their risk for inflammation. And so we're going to talk about all of those things today. So I do not have any disclosures. So the goals for today's discussion, we're going to go over the prevalence and causes of obesity, as well as the genetic contributions, which I really like to discuss in every talk that I give. We'll review how heart disease actually develops and what role inflammation and obesity play in that structure. We'll also discuss how to measure inflammation and where that fits in with other important health testing. And finally, we'll review ways that you can personally reduce inflammation and improve your health overall to reduce your risk for heart disease. So without further ado, we will jump right into heat maps of obesity across the US. So these are predictions and a history of the rates of obesity across the US in the past, starting in 1990, leading up to the future. So on the left, we're looking at overall obesity across the US, and on the right, we're looking at severe obesity. So you can see back in 2000, everywhere we're seeing that patients had obesity, but there weren't very many patients with severe obesity, meaning BMI over 35. But as time has gone on, obesity has increased across the US, and we're seeing severe obesity pop up as well, and we anticipate more into the future. So there's not really any part of the US that's not affected by this, but it is more common in certain areas, as you can see. We do anticipate that by 2030, nearly 1 in 2 adults will have obesity. And we see these same trends globally as well. So in 2021, about 2.1 billion adults in the world had obesity. And we expect that by 2050, that number will almost double. So it'll be up to 3.8 billion, representing about 60% of the adult population. So all the more reason to talk about this important subject and how we can address it. So first, I think it's important to discuss how we actually define obesity, because there's not just one way. For the longest time, we've used BMI, which is a pretty simple, quick calculation that we can do in clinic using a simple formula of height and weight. Doesn't require any extra supplies. You can just use kind of what you already have in clinic. Um, but the problem is that a lot of patients are not very well represented by this formula. So we all may know someone who is a serious athlete or a bodybuilder. They have really high muscle mass, and that will increase their weight and it will make the BMI look high. But that person, when you look at them, it really doesn't seem like they actually have excess fat tissue, which is what we're really important or what we're really kind of looking for when we talk about obesity. Does this person have excess fat or adipose tissue, and is that going to lead to an increased risk of disease? So BMI is a good starting point, but we have more and more ways to assess body composition now, and there's still a lot of studies that need to be done in this area, but we now have bioelectrical impedance scales, which we can do professionally both in the office, but you can actually purchase these for use at home as well. And some are pretty reasonable. There's some that are only $30. They go up to $200. And that can help measure not just your weight, but also the amount of fat tissue that's actually in your body as opposed to muscle or water. We also have DEXA scans, which is a type of scan that we've traditionally used to look at bone density, like to see if patients have osteoporosis or brittle bone disease. But that same scan can actually look at body fat percentage as well. And then we have even more advanced methods, which are used more so in research, called whole air displacement plethysmography, or the BOD pod, which is like a specialized pressured pod where you sit in wearing only like a spandex outfit, and it looks at kind of the way pressure changes to estimate the body fat percentage. But unfortunately, none of these scans are one, covered by many people's insurances, two, standardized. So if we have someone that goes and gets their body composition scanned at the via the BOD pod, they get the DEXA scan, they get bioelectrical impedance scan. They'll all show slightly varying numbers. There are all certain reasons why some patients may not be able to use some of these, like bioelectrical impedance, you cannot use if you have a pacemaker or implanted cardiac device or if you're pregnant. And DEXA scan does have weight limits. So there's all kind of different reasons why these aren't perfect. Um, and the other thing is there's different agreed on percentages of body fat that are too high. So some studies suggest in men, if body fat percentage is more than 25 or 30%, that qualifies for obesity. Some for women is more like 35 to 40 or even 42%. But it's just another way to kind of look at the body and whether this is actually obesity. And then finally, a little bit of an easier way that kind of bridges the gap between our easy but kind of unreliable BMI and our very advanced but expensive and not readily available body composition scale is to do a waist circumference, which is just a simple waist measurement at the top of the hip bone. And we can determine if someone, seems to meet criteria for obesity based on that. And we do have different cutoffs based on kind of your background and ethnicity. It seems like based on prior studies that those who are from Asia or South America tend to develop more visceral fat, meaning the fat that's surrounding the organs at lower weights. And that's why there are slightly lower obesity cutoffs for patients from those regions. So what is my approach? We do still start with the BMI because that's the easiest way to measure someone's body composition very quickly in the office. If BMI is very high, like above 40, it's almost guaranteed that the patient has obesity, and doing these additional scans doesn't add a lot to help us decide what to do next. But if we have someone that's kind of in that intermediate range, like their BMI is between 25 to 40 or even 23 to 40, then it's helpful to add a waist circumference measurement to see if that is also high. Then you'll have kind of two different data points that are in agreement and can tell us if someone actually is at risk for metabolic problems from their higher weight. So I love talking about the genetics of obesity because I think sometimes I think what a lot of patients that I've seen with obesity tell me is that they might go to the doctor will say, oh, it's so easy to lose weight. You just, eat less and you exercise more, and that works for everyone. But the reality is that everyone is born with different genetics and everyone has different risk factors for obesity. And so what works for one person may not work very well or may not work at all for another person. And we are really living in an exciting time because we have kind of like a boom of knowledge about genetics. So what this is are different gene studies that showed different linkages to obesity. So in 2007, we had barely any studies that showed, what genes predisposed patients to gaining weight. And as of 2020, we have thousands of studies. And you can see they did break it down by kind of ethnicity. And you can see that most of the studies were done in European patients. So we definitely need a lot more studies in those of other backgrounds. But in general, we've discovered that there are many, many genes that can influence your risk for obesity. At least 750 gene locations can contribute to weight. And what do I mean when I say this? So there's some genetic forms of obesity that are quite rare, where someone will have one or maybe two significant gene changes or malformations that will make them develop severe obesity in almost every circumstance. So really what that person does, diet and exercise wise, they're always going to have obesity. But this is only in very rare circumstances, like patients with rare conditions like Prader-Willi or Bardet-Biedl. What most people have when they are struggling with their weight is what we call polygenic obesity, which means that there are 5, 10, 15, 20 different changes to their genes compared to someone who doesn't struggle with their weight. That increases their risk of gaining weight over time. And when they've done these studies in mice and in humans, different genes can predict how much food you will eat at a meal, how much you crave more sugary food, how much you crave more fatty food. And all of those things are biological urges. I think one of the most important urges or things that we do as humans is eat to keep ourselves alive. And so it goes beyond just kind of like, what you feel like eating. It's what you feel like you need to eat to keep yourself alive. So what I really want to highlight is that weight is influenced by genes as well as environment as well as lifestyle in all patients. And for some people, genes may have a really strong contribution to weight. So it may be extremely difficult for someone with a bunch of genetic changes to lose weight. But for other people, it's really kind of a minor contribution. And what the environment that they live in and their lifestyle really can make a bigger difference than for other patients. So there's an adage in medicine, which is that for every 3,500 calories that you cut out, you'll lose a pound. But that I don't believe in that, and I think anyone who tries to lose weight knows that that's not true, because if that were the case, then patients would steadily lose weight and then cease to exist. And we know that that doesn't happen. And that this is a graph and a joke that I stole from a very prominent weight and obesity researcher, Kevin Hall, in the government. Um, so what actually happens when patients lose weight? And I'm not going to go into these studies in super detail, but basically we've tried to figure out, is it metabolism? Is it appetite? What is it that makes it so hard for patients to be able to steadily lose weight? So here's a really interesting study where they gave patients instructions to reduce their calories every day. And as time went on, they steadily lost weight. However, as things kind of continued, they were losing less and less weight, and some of them steadily regained weight, even though they were trying their best to maintain this calorie deficit. And we did notice in these studies that the patient's metabolism, or what we call energy expenditure, did decrease a little bit, which definitely contributes to it being hard to maintain weight loss. But appetite majorly increased as patients lost weight, and as they perceived themselves to be adhering to a certain calorie deficit, it became harder and harder and harder to fight against that biological urge to eat. So in general, about every kilogram of weight loss, patients notice that their appetite increased by 100 calories per day. And that's one of the many reasons that it's so hard to lose and maintain weight. And we have this idea of a physiologic or biologic set point where all of us kind of have a weight where our body likes to be at. And it's very hard to both gain and lose weight beyond that set point. And all of this is happening subconsciously. Patients aren't, deciding, okay, now I want to gain a bunch of weight back. Most people are really trying their best, but biology is fighting against them. So my example is two people. One is someone who, has their genetic makeup that doesn't show any risk for a gene that might cause them to gain weight. So this person, when they eat, they just feel full after eating the appropriate amount of food, and that's it. If they overeat one day, it's Thanksgiving or their birthday, they have a big piece of cake. The next meal, they just don't feel as hungry, and so the body kind of naturally regulates their weight without them having to really think much about it. But if we have someone who, for genetic reasons, is not really able to tell when they feel full or not able to tell when they feel hungry, they have to kind of left brain it. They have to purposely track all of the nutrients that they take to kind of make sure that they're not overeating. But it's very easy to make a mistake when you're doing this. Even studies of doctors and nutritionists show that we make mistakes all the time, and we're not very, it's very difficult to perfectly count exactly every single thing that you're taking in. And it's very easy to take one or two extra bites, which really isn't even something you can measure. But over time, if at every single meal you're taking two more bites than the person next to you, then you will gain weight over time. So there's this concept of health at every size. Is there health at every size? And my take is that both can be true at the same time. We do know that obesity in general increases the risk for heart disease. However, not everyone with obesity has or will have heart disease. So that brings up this concept of preclinical versus clinical obesity. So preclinical obesity are when you have someone who has excess fat tissue by, BMI, waist circumference, body, or bioelectrical impedance, etc. But when you look and you do a thorough evaluation, you don't see that they have any evidence of metabolic disease. Their blood pressure is perfect. They don't have diabetes. Their cholesterol is great. In general, they're feeling well. This person has obesity, but they don't seem to currently or may never develop any cardiac disease. However, some patients may move into the clinical obesity category, which is that they have excess fat tissue and they also have an obesity related condition or maybe multiple obesity related conditions. So in the heart realm, that could be high blood pressure, heart failure, could be plaque in the arteries or what we call atherosclerotic disease, could be irregular heart rate like atrial fibrillation. In the endocrine world, it could cause diabetes, it could cause PCOS or male hypogonadism or like low T, you might hear on commercials. Could be sleep apnea, liver disease, or there might just be a problem from the gravity of just carrying around extra weight, which can cause hip pain, knee pain, and decreased mobility. So all of these fall under the clinical obesity category. And when I see someone with obesity, not every single person does need to be treated, and this is one of the ways that I help patients and myself together figure out what's the best course for them. Do they have signs of clinical obesity, or are they really more in the preclinical obesity? And it's just something that we can kind of monitor. So how does this play into the heart? So how does heart disease develop? I have a very rudimentary formula that I've come up with. So one is heart stress and high cholesterol and time come together to form heart disease. So our goal as doctors is to reduce the amount of heart stress, which could be high blood pressure, it could be inflammation, it could be high blood sugar, anything that puts stress on the heart, reduce cholesterol, because we're all working on the same timeline. We're all living, the same days and the same years. So we want your cholesterol and your stress to be as low as possible for as long as possible to reduce your risk of heart disease. So, how does heart disease begin? When you're born as a baby and a child, you have all these perfect arteries, which have layers of muscle, and the blood kind of runs through the middle to go where it needs to go in the body. Throughout life, and this happens even when we're children, before we can even do anything about it, naturally there are stresses to our body. So, like I mentioned, there could be inflammation, the blood pressure could be high, there could be all these different things. That cause a small tear in the artery wall. So then fat comes in and it starts to lay itself down in the center of the artery to kind of plug up that hole that the tear or inflammation has created. And over time, it can become excessive And either the fat itself can block up the flow of blood, or you might have a small blood clot that blocks up the hole. And I think that really important thing to be aware of is that these first three stages are totally asymptomatic. So if you have a small tear in your artery, or if you have some plaque in your arteries, most patients do not have any symptoms at all that they have that. And it's only suddenly when they get a certain amount of arteries blocked that you have symptoms. And now our body is pretty smart. When it starts to become blocked, it develops what we call collateral circulation, which is that there's usually multiple arteries or multiple roads to get to the destination. And so if there's an artery going in one place and it becomes blocked, there's a couple other arteries that the blood can flow through. And also the arteries can kind of stretch if there's a bit of fat in the walls. But there's a certain point when our body cannot compensate anymore, and that can cause a heart attack, and it can cause other problems elsewhere in the body, because obviously we use blood vessels to go everywhere in the body. So, the blood vessels feeding the brain, if those get blocked, that could cause a stroke. The blood vessels feeding the kidneys, if they become blocked, you can have a kidney injury or chronic kidney disease. And then the blood vessels feeding the arms and legs could become blocked, and that can cause peripheral arterial disease, which can lead to amputations and just poor circulations in the limbs. So taking a step back, I mentioned inflammation can cause these tears in the arteries, and but what actually is inflammation? I think we all know that inflammation is bad and that we want to reduce inflammation. But what is that? Why does our body do that? So inflammation is actually the body's natural response to damage. So if you have an injury, if you have an infection or a sickness, the immune system releases these messengers, which we call cytokines, that come in to fight the infection. So if you're sick, the immune system is responsible for raising your temperature, aka a fever, to help kind of burn off the bacteria or the virus that it's currently fighting. The messengers also recruit more cells from the immune system. They might kill certain cells in your body that are either not working well, or maybe the bad cells from the bacteria. And sometimes this works perfectly, but sometimes the immune response gets too strong, or it might fight against things that it shouldn't. And that's kind of how autoimmune disease begins. Our immune system fights against a normal function of your body, and that can cause that function to no longer work as it should. So what causes inflammation? There's a lot of different things. As I mentioned, illness or infection, it's a normal response of the body to release inflammation to fight the illness or infection. But if it's inappropriate, that can cause autoimmune disease. Our emotional or physical stress can also increase inflammation. Poor sleep or sleep apnea, smoking is a big one, diabetes, as well as obesity. And there's even more causes of inflammation that we're still studying and becoming aware of. How does obesity cause inflammation? So I mentioned before that there's this concept of visceral fat, which is the fat kind of surrounding the organs, which is worse than the fat that we just have below our skin that's meant to be there and kind of insulate us and be there to be turned into energy if we haven't eaten for a while. The visceral fat that's surrounding the organs actually helps stimulate and recruit those cytokines that I mentioned, the messengers that cause your immune system to be overactive. All fat tissue is actually an endocrine organ. Endocrine means like a hormonal releasing organ. And fat does release the hormone leptin, which is a hormone that normally helps us tell when we're full. Like after we eat a meal, our leptin levels go up. But in all patients with obesity, leptin is naturally higher. And that has been shown to be associated with increased inflammation levels as well, even though it also does an important job of telling us when we feel full. High blood sugars in patients with diabetes can also cause oxidative stress to blood vessels, which can weaken the blood vessel walls. So I've just told you all these bad things that inflammation does. What can we do, and can we measure it? So we actually do have a test for inflammation, specifically as it relates to the heart. So it's called the high sensitivity CRP. And there actually is another test called the CRP, which is a bit different, and we use that for monitoring sometimes like autoimmune conditions. So as it relates to the heart, we're looking more at the HS-CRP. And when that level is over 2 milligrams, it can increase your risk for heart disease. But we don't always recommend checking that in every person. So the American Heart Association recommends checking it in people who are at kind of borderline or intermediate risk, versus the USPSTF, US Preventative Services Task Force, which is the guidelines that most primary care doctors follow, says that they don't feel like there's enough information to recommend that testing at this stage. So I brought up this cartoon because it kind of reminds me of this. So I've just told you we have this amazing new cat tree, but I want you to still use the box, even though we have this option available. So the reason that we do that is because in medicine, there's always 1,000 tests that we can do, but we want to choose the tests that are going to be the most impactful and that will most help decide what to do next. So I want to go over the 5 main risk factors for heart disease. These are high blood pressure, high LDL, which is the bad cholesterol, low HDL, which is the good cholesterol, diabetes, and smoking. And you may notice that inflammation is not one of the 5 main risk factors, which accounts for 90% of cases of heart disease. But you may also notice that a lot of these things that are listed were also listed in things that can cause inflammation. So there's definitely overlap between the two. So how do we go about deciding who to test, when to test? So you can scan this QR code, which I was very proud of myself for creating, to calculate your risk score. You will need to have some recent data from seeing your doctor. So if you go, I recommend for all patients to have a yearly physical with your doctor so that we can actually listen to your heart and lungs, hear if you're having any symptoms, check your blood pressure and heart rate, and then check some standard labs. So we, in all patients, will update a cholesterol panel anywhere from every 3 months to every couple of years, just kind of depending on your personal risk factors. We may be testing for diabetes, especially in those who have a history of maybe pre-diabetes or a prior history of diabetes, or those with obesity, and kidney function testing as well, which is called like a COM7, BMP, or CMP. And then using these results, your doctor will be calculating an ASCVD risk score. But I like this to be in the hands of the patient, so that in case they forgot or they didn't tell you what the result was, you can calculate it yourself. And then we use that score, which tells us your risk of having a cardiac problem, like a heart attack, in the next 10 years to decide whether we should start a medication or if we can keep monitoring. So this is straight from our cardiology guidelines. So if you are someone who has more than 20% risk of a heart problem in the next 10 years, then you almost certainly should be started on some medication to help with your cholesterol. If you're someone in the intermediate risk category, 7.5 to 20% risk, you almost certainly should be on a cholesterol medication, but it of course depends on whether you've tolerated them in the past and other risk factors. But this category of people that are in the borderline risk score is the people that would benefit most from additional testing. So other things that can, we think about, even if you've had, low risk, your cholesterol looks good, things that might raise my suspicion that you might still be at risk for heart disease would be if you have a strong family history of heart disease, especially if people had heart disease young, like below the age of 40, 45, or 50. Other things that can raise risk for heart disease are, as I mentioned, autoimmune disease, kidney disease, a couple of conditions that affect women. So preeclampsia and premature menopause can also increase the risk for heart disease, HIV as well. So that might push us more into the category of wanting to, discuss a cholesterol medication. But you can do these additional tests, the lipoprotein little a, the high sensitivity CRP, and the ApoB, which will help further stratify if you would benefit from being on some sort of a cholesterol medication. And I do like giving resources as well. So you can, you don't need to see your doctor. You can get a blood pressure cuff over the counter for anywhere between $15 to $50. Although if you have high blood pressure, your insurance should cover it. You can also order these tests yourself if you just kind of want to see the results. And sometimes the test may be a little bit less expensive to do it this way. So the website is walkinlab.com. It's $39 for a cholesterol panel, $49 for lipoprotein A, and so on. And you can go to a LabCorp request to get it drawn, except in certain states. And that can help you decide, you and your doctor decide, if you should consider a medicine or if you work on lifestyle and so on. So, can we treat inflammation? Yes. And the good news is a lot of the medicines that we would already use to treat high cholesterol also help with inflammation. So, our statin medications like Lipitor, Crestor, and so on, had a really exciting, like landmark study back in 2008, where about 18,000 healthy patients with relatively okay cholesterol but high CRP, HSCRP, were given a cholesterol medicine or given placebo. And after 2 years, they found that the medicine group had a huge improvement in their cholesterol, but also a huge improvement in their CRP, and most importantly, 50% reduction in heart attacks and strokes. And whenever we have a study in medicine that is really, it shows a huge benefit, they stop the study early. And that happened in this study. They didn't, once they realized after a couple of years that these patients were doing so much better on the cholesterol medicine, they decide, hey, we shouldn't study this anymore because we want to give those people in the placebo group a chance to be on this medicine. So that happened in this study. Another cholesterol medicine that we use a lot called ezetimibe, or Zetia is the brand name, also was proven to decrease HSCRP in the Improve It trial. This was only at 1 month, but it did show a 16% reduction when adding that in. And weight loss and exercise also are proven to decrease HSCRP and cardiovascular disease. So this was a great study in patients with diabetes called the Look Ahead trial, where they gave them instructions and teaching to do intensive lifestyle changes, and those patients were able to lose about 8.8% of their weight after 1 year, which is really successful. Many other studies, patients tend to achieve like 3% weight loss or so with diet and exercise only. And in that group, the HSCRP did decrease a huge amount, 43%, which is similar to what the statins did actually. Um, this is a large study called a meta-analysis, which is where they basically look at a bunch of different research papers, about 40 different papers. They smash them all together, all of the patients, all of the data, and they see what that showed all together. So it's considered to be much stronger data than just one study on its own. Because you get, instead of getting 100, 500 patients, you get like tens of thousands of patients. And this combination of studies, which was both trials where they had patients do diet and exercise, but also a study where patients had surgical weight loss procedures. In general, patients lost, for every kilogram of weight lost, they lowered CRP 0.13 milligrams, which is a big deal when the normal number is 2.0. So I know, I just think 0.13 doesn't sound like very much, but when you put it into the context, it actually makes a huge difference. Um, and our GLP-1 medications like semaglutide, Ozempic, Wegovy, tirzepatide, Mounjaro, Zepbound also are shown to lower inflammation, both by causing weight loss, because I already mentioned how weight loss leads to lower CRP, but there also seems to be a direct um, effect on the immune system to lower inflammation. So they also saw that the HSCRP was lower after 24 weeks. And I know you've had a lot of great lectures in the past about GLP-1 medications, so I didn't want to talk too much about them, but I cannot help but have one slide about the GLP-1 medicines. So GLP-1 is a hormone that your intestine normally releases. It helps slow your stomach emptying. It helps reduce hunger signals in the brain. It also has a what we call an incretin effect, where it helps the body be more sensitive to insulin, and it helps the body release more insulin only when it needs to. So when your blood sugar is high, it helps you release more insulin, and if your blood sugar is normal or low, there's no increased amount of insulin. So it's really a smart effect that helps patients improve their blood sugars without causing low blood sugar when used on their own. All of these medicines, Victoza, Ozempic, and Trulicity, have been proven to decrease risk of cardiac disease in patients with diabetes. And our landmark trial, which came out a little bit over a year ago, the SELECT trial, which was the very first trial that showed any weight loss medicine in patients with obesity without diabetes, reduced the risk of heart disease. So that was a huge deal. And we anticipate that studies including tirzepatide, which is branded as Mounjaro or Zepbound, depending on whether you're using for diabetes or weight. We anticipate it will show the same, but technically the study is still ongoing. So that should come out in the next couple of years, and then we'll know for sure. But in general, all the data that we have with our GLP-1 medicines is really promising that they help with weight loss, they help with heart disease, and they help reduce inflammation. I want to end by talking about lifestyle medications because I've talked about all these different studies that showed lifestyle medications and weight loss are really helpful. So in general, the exercise goal we set is to try to get at least 150 minutes per week of moderate exercise over the course of the week. So moderate is like fast walking, um, or slow jogging. Or if you are someone that prefers vigorous exercise like basketball, sprinting, only 75 minutes per week is needed, although more is better. There was a really cool trial that came out earlier this year where they saw that patients who only did 5 minutes per day of more vigorous or strenuous exercise reduced their risk of heart disease by about 30% or so, and reduced their risk of death by 40 to 50%. So it doesn't take, you don't have to be doing hours every day. Just 5 minutes of vigorous exercise per day is helpful. And I really like to emphasize that to patients. Even if you're doing absolutely zero exercise, 1 minute is better than nothing. So, and I think it's easier to set a goal if you've kind of been out of practice to be like, you know what, I'm going to go to the gym and I'm going to walk for 1 minute, or I'm going to go and I'm going to do one sit up. And some days that may be all you do, but if you get to the gym, you may find a lot of days you do more than that. And that's, I think, the key um, to meeting exercise goals. There's also a lot of diet recommendations that I give. So increasing fruit and veggies, which also kind of goes along with increasing fiber, is really helpful. Fiber is a really good tool to help lower cholesterol. Decrease processed foods like fast food, packaged foods, sugary drinks, and red meat. And all of these kind of come together to um, be represented by the Mediterranean diet, which is a diet that you'll find a lot of cardiologists, endocrinologists, et cetera, recommend. It is a really research proven diet. There were huge trials in 2013 and 2022 where they compared patients who were on more of a low fat diet versus patients that were on a Mediterranean diet, and they saw that these patients had reduced risk for heart disease. And that was true for both patients who had no history of heart disease and patients who had like heart attacks or some heart disease in the past. Um, I also want to highlight that it is ideal to avoid fluctuations in weight, like yo-yo dieting. There are some studies that show that big increases and decreases in weight can actually increase cardiovascular risk. So all the more reason why it's better to kind of slowly have weight decline over time um, in a steady and manageable way. And finally, I want to highlight that exercise and diet is really helpful, even if you don't lose any weight. And so I like to encourage patients to make goals for exercise or diet that are not weight related. Like if your goal is to walk on the treadmill for a certain amount of minutes, or your goal is to do this many push-ups, or do it, over X amount of time, I think that really helps keep patients going because even people who are being super consistent, you're not going to lose weight every single week, even if you're, doing everything that's recommended. So that can be discouraging. And that's why it's good to have secondary goals. Finally, I'd love to highlight this study. I find a lot of people find this to be a good take-home message. So this was a study that was done at Brown in 2014, so 10 years ago at this point. They had about 3,000 patients who had lost 30 pounds and were able to maintain it for at least 1 year after losing that weight. And they looked at what was in common between these patients. And in general, they all had very high levels of physical activity daily. It didn't have to be vigorous, but just something daily. They ate breakfast every day. They watched less than 10 hours of TV weekly, and they had weekly weigh-ins. So these are quick tips that I like to share with patients as they get on their weight loss journey. So finally, I have some take-home points. I wanted to emphasize that some people are at higher risk for obesity and heart disease than others, but everyone benefits from diet and exercise. Many of the same things that can cause inflammation also cause heart disease. Early heart disease is asymptomatic, and so that's why it's important to have routine checkups and testing to help us identify whether you are someone that is at risk for heart disease and help us, reduce your risk so that you have less amount of cholesterol and less amount of heart stress over time. Many of the same medicines that treat heart disease also treat inflammation, and lifestyle changes decrease the risk for inflammation, obesity, and heart disease. So thank you very much for having me here today. I do have a picture of my cat wearing a banana costume, reminding you to eat fruits and veggies, and I would be happy to take any questions.
Thank you, Dr. Ponder. That was incredible. So much great information.
Thank you.
As you guys have questions, please put it in the Q&A. We do have one question here. Could you describe a little more about how inflammation creates heart disease, even if your cholesterol is okay? Is it all because of the leptin? Would something like a horrible dental disease cause enough inflammation to cause heart disease?
Yeah, that's a good question. I'm going to go back to this slide. So it's not all because of the leptin. So leptin is, a pro-inflammatory hormone that helps release those cytokines, but also that fat that's around the organs, just on its own seems to recruit cytokines, which are those messengers that tell your immune system to be more active. And I also mentioned not all with obesity have higher blood sugars, but some do, and that can also lead to additional stress. So basically, they're what we call like reactive oxygen species. They come in and they directly lead to damage in the wall of the artery. So when you hear people talking about like a antioxidant, the purpose of an antioxidant is to take away these reactive oxygen species. But the immune system also goes in and it might kill certain cells that it thinks are not functioning properly, even if they are. And those are all kind of different ways that the heart or the arteries can be hurt. And then the second part of the question regarding dental disease. So yeah, dental disease I think is a really under recognized contributor to heart disease and to health problems in general. Our mouth carries a ton of bacteria. Even in people who have the best dental hygiene, we know that because of we put food and liquid into our mouth all day, that exposes us to a lot of bacteria. And if we have cavities that are unaddressed, that can enter the bloodstream through the gums and the blood supply in the teeth. And that itself is a source of inflammation. So because that is an infection and a bacteria that the immune system has to work to clear. So dental disease, I mean, it can increase it can increase inflammation to cause heart disease, but it can also, I mean, I've seen several patients develop infections that involved the heart, and that can be very serious as well, and it can be deadly for sure. So I love that you brought up dental disease because I think that is a really important component of health and reducing heart disease risk.
Let's see. Thank you. We have another question. Would you recommend that people with constipation issues avoid semaglutides?
That's a good question. It depends on the patient. I think that if someone has somewhat mild constipation that is manageable with either diet, or supplements or medication, then they could still be a candidate for using semaglutide or any of the GLP-1 medications. The main tips that I give patients who are on these medicines is to increase fiber intake, because that is really helpful with constipation. Increase hydration, because obviously dehydration can make the stools more kind of like hard and harder to pass. And there are a couple of supplements that are helpful. So psyllium husk, you can just buy psyllium husk at a health food store. You can just scoop it out, or Metamucil are two good fiber supplements that help with constipation. So I find some patients can manage things pretty easily with those or with a prescription stool softener like Miralax or Colace. And it's really interesting because the study of the GLP-1 medicines shows that about half of patients that basically patients are equally as likely to have diarrhea as they are to have constipation. So occasionally I do see patients who may have one or the other. They started a GLP medicine and it kind of is the perfect match for them. They may have diarrhea, they start the medicine, and the medicine causes a bit of constipation and they kind of end up having normal bowel movements, or it may be the opposite. So I think the answer would be it depends how severe it is, and certainly I would be really cautious when starting these medicines to make sure that those symptoms aren't worsening. Might use a lower dose for longer, a slower titration, those sorts of things. But certainly if the side effects got a lot worse, and patients were going weeks without a bowel movement, then maybe they're not a good match for that medicine.
Okay, thank you for that. The next question, I take Lipitor, atorvastatin. Did you
Mhm.
say that there's a better statin based on recent tests?
So there's a little bit of differences of opinion on atorvastatin versus rosuvastatin. So the two most powerful statin medications are atorvastatin and rosuvastatin. The data does show that rosuvastatin, which is branded Crestor, is a bit more effective at lowering cholesterol. That being said, many patients do very well on atorvastatin, and if I had a patient that was doing very well on it and they didn't have side effects and their cholesterol was at goal, I wouldn't really see any reason to switch them. It may just kind of depend on which your doctor favors, because you will hear differences of opinions between doctors. It just happened to be that this study, used rosuvastatin, but that doesn't mean that atorvastatin doesn't do the same thing in terms of lower. In general, the data shows us that all statin medications lower cholesterol, of course, and lower the CRP. So yeah, you're on a good medicine. Atorvastatin is definitely one of the top ones.
How do those two compare in terms of side effects?
So in general, the Crestor I find it's a little bit better tolerated by patients. So I would say most patients that take cholesterol medications have no side effects. And actually, in this particular study that I mentioned, the Jupiter study, there was actually no increased incidence of side effects. The main thing that we look for is muscle pain. Some patients rarely may have like kind of all over body aches or muscle pains that are, or even like muscle damage, but that is a pretty rare person, and most people tolerate them very well. In general, rosuvastatin may have slightly lower risk of those side effects than atorvastatin.
Okay, thank you. Let's see. Any other questions? Feel free to put it into the Q&A. I'm looking at the chat as well, so if you're more comfortable putting your questions there, please feel free. Let's give folks a couple more moments here. Somebody
Yes,
says that,
I have
thank
a
you so
question,
much.
Karen.
Oh,
Sorry.
all right, go ahead,
From
Mandy.
Dr. Ponder. As people become more aware of what inflammation is, are you having conversations with your patients more frequently now than you were, say, 2 or 3 years ago? And what role do you think it will play in future diagnoses for people?
Yeah, I actually I think the way that it comes up for a lot of patients is some people are like, I've heard about an anti-inflammatory diet. Should I be doing an anti-inflammatory diet? But my answer to that is usually because sometimes I go on the internet and I like pretend I'm a patient and I see like when a patient Googles and they Google what is an anti-inflammatory diet, there's all sorts of different advice. Which some of which I would agree with and some of which I wouldn't. So, the Mediterranean diet that I mentioned is an anti-inflammatory diet in that, it lowers cholesterol and it has, red meat and smoked meats are kind of more inflammatory than fish and chicken. And so that's more kind of what I would recommend. But then I've seen all this wild stuff about different types of foods being inflammatory. So that's how it usually comes up. When I don't I haven't had a lot of patients bring it up when we're talking about cardiac risk actually. But it's something that, now that we have the HSCRP and there's more data coming out for it, it's something that I think about testing more in patients who may have either a history of heart disease that is kind of unexplained, like their cholesterol is great, their blood pressure is great, they're otherwise healthy, and they like suddenly had a heart attack out of nowhere, then that's someone where I want to do further investigation. Or someone who, has a history of autoimmune disease or other things that make me think they might have a higher level of inflammation in the body. But really, at the end of the day, it's kind of the same medicines and the same treatment, whether or not inflammation is high. All the same medicines and everything have the same, benefit inflammation. So I don't think that it is like, I guess, required to do this testing in every person, kind of in line with how what the societies have recommended. But it can be helpful or motivational, I think, for certain patients to know these numbers, and have something to kind of think about when they're making their lifestyle changes.
Thank you.
Mhm.
Another question, does Repatha have the same effect on lowering CRP levels as oral agents?
That's actually a great question. I actually am not sure. And I may just not have seen the data on that. Obviously, Repatha is a newer medicine. It's one of our strongest cholesterol medications that we're recommending for more and more patients who either cannot get their LDL to goal with the medicines that we have, or patients that just can't tolerate statins for whatever reason. But yeah, I do not know the specific level or effect that it has on HSCRP. But I would think that it would have the same effect, given all of the other cholesterol medicines do as well.
Okay, and do statins increase A1C levels?
Yeah, that's a great question. So there is a very small increased risk of diabetes or higher blood sugars with statins. And I think I'm a good person to ask because I am an endocrinologist and I treat a lot of patients with diabetes. We always weigh the risks and benefits. In general, I don't want people that do not have any risk factor for diabetes to worry that they're going to develop diabetes when they start the medicine, because that really um, it isn't the case. It's more like patients that are right on the border, that we worry more about, like maybe their A1C is 6.4, right, very close to that cutoff for diabetes, where we get a bit more, or we might want to watch more closely. But in my opinion, the benefits of statin medications outweighs the potential negative effect on blood sugars, because of how powerful they are in reducing the risk for heart disease. And I think most other physicians would say the same. Especially because we have so many great treatments now for blood sugars. Ranging from GLP-1 medicines to metformin to 20, 30 different medications, as well as diet and exercises together. So the short answer is yes, but I think it is very minor, and it is worth that risk in most patients if we're recommending it.
Okay, looks like we're going back to the teeth.
Okay.
This question says gum infection often has a lot of anaerobic bacteria
Hmm.
in high turbulence areas. This
Hmm.
is similar to inflammation in an artery. Is flossing, brushing, and water picking helpful to reduce heart inflammation?
Yeah, absolutely. Because when you floss or water pick every day, that helps break up the what we call like a biofilm of bacteria. So if you have bacteria around your mouth, which again is normal, it doesn't mean that you've done anything wrong. It's all people have bacteria in our mouth, but if it sits there and you haven't flossed, it builds up a biofilm, which is kind of like a layer of bacteria that allows it to grow and proliferate and maybe eventually become a cavity. So when you floss or water pick, you kind of break up that layer, and it helps prevent more bacteria from sticking to that area. But there are studies that, or we know that when patients have, more significant dental procedures, that can release some bacteria into the blood, and that's why some heart patients, like patients with artificial heart valves, might be recommended to take prophylactic antibiotics before they have a significant dental procedure, because we know that they're already at higher risk for bacteria kind of sticking to the heart, and those procedures release bacteria into the blood. But there's no question that they are helpful for reducing the risk for disease. And I wish that more insurance companies would, or that dental insurance was considered a part of uh, of health insurance, because I think it is so important, as a part of health. But teeth are kind of like seen as a separate thing,
Yeah.
insurance wise.
Yeah. Very interesting question. Okay, how does long-term use of Crestor or Lipitor affect your body? For example, 15 to 20 years. Are there long-term negative effects to being on these statins?
I mean, any medicine, there's always a possible for a negative effect long term. But what we've seen with statins is that if you're going to have a negative effect, like if you have muscle pains or something, it's more likely to happen in the beginning, and we'll know about it early on. Kind of long, it's unusual for patients to suddenly develop problems long term. In general, long term use of statins is associated with, strongly decreased risk of heart disease and strokes. And there was some kind of back and forth about whether, there was, what role it played in dementia, and recent studies have really shown that it decreases the risk of dementia as well, just because, our arterial and plaque in the brain is an important cause of dementia. So keeping cholesterol lower over a longer amount of time, decreases that risk. So in general, long term, you're primarily seeing benefits. But of course, you'd have to, assess things with your own doctor, make sure you're not having any side effects, because of course, we would never recommend a medicine if you were having a problem to be on it for 20, 30 years.
Okay, thank you.
Mhm.
Any other questions? We've got a couple compliments here. Thank you so much. This was great information. Somebody else, wrote great food for thought, that kind of thing.
Thank you.
Let's see. Let me just look in one more place. Yeah, so I think we have addressed everybody's questions. So,
Okay.
Dr. Ponder, we really appreciate your time this afternoon. I learned a lot. I took a lot of notes, and it was a great reminder how we can all, have a little bit more control over what's happening in our bodies and our goal
Mhm.
for, maintaining better health. So, I personally appreciate your time, and I think everyone on the call is super happy. Yeah, we just got another message. Thank you for all the information. So, anyway, stay cool
Thank
wherever
you.
you are. We were talking before this
Yes.
webinar started about the importance of staying hydrated. So, let's all take that to heart. Let's stay hydrated. And thank you, everyone, for joining.
Yes, thank you so much for having me.
Have a nice afternoon, everyone. Bye bye.
Bye.